Hello, it's lovely to speak to you today. My name is Terri McVeigh. I'm a consultant clinical geneticist in the Royal Marsden in London. And today I've been asked to speak to you about the cancers that are associated with BRCA1 and BRCA2 gene alterations, other than breast and ovarian cancers, which tend to get most of the attention. So I'm delighted to speak to you on this topic. I'm sorry I can't be with you live, but I'm sure the team will be happy to pass on any questions that you may have, and I'll do my best to answer them offline. So I know this will be familiar with most people in this audience, but I think it's important to set the scene and just explain what we mean by genes and genetics. It's a very complicated topic, but to keep things very simple, the way I think about your genetic information, it's basically the instruction booklet that our body follows to know how to grow and develop. And every cell within our body will contain this genetic information. And it's a big long string of chemical bases that are each represented by a letter. And genes are basically just chunks of that genetic material that we inherit from each of our parents. And when we do genetic testing, what we're looking for are subtle changes within this genetic sequence. So a swapping of one of these chemical building blocks to another, or removal or addition of some of these chemical building blocks. So the way I think about it is when you're doing genetic testing, you're basically doing a very sophisticated spell check to make sure that the sequence is correct. If you have a spelling mistake or an alteration within a gene that's supposed to prevent the development of cancer, then obviously your risk of cancer is going to start to increase quite significantly. So this brings us on to BRCA1 and BRCA2, and you might have heard of them referred to as tumor suppressor genes, and they sort of do what the name on the tin suggests. They suppress the development of cancers, and the way that they do that is by repairing damage to the cell DNA. So they're also sometimes known as DNA repair genes. And if we inherit a spelling mistake in one copy of either BRCA1 or BRCA2, that function in terms of suppressing cancer development is lost, and that can lead to an increase in the risk of certain types of cancers. So usually we each have two copies of BRCA1 and two copies of BRCA2. And the reason we have two copies of each of these genes is we get one copy from our mum and one copy from our dad. And the way that alterations in these genes are inherited doesn't matter whether you're a biological male or a biological female. So every child, be they son or daughter, and every sibling, brother or sister, of an individual who carries an inherited alteration in either BRCA1 or BRCA2 will have a 50-50 or 1 in 2 chance of inheriting the same gene alteration. And the reason I'm elaborating on that quite a bit is there's this urban myth out there that men can't carry these gene changes. That's not true actually. So men as well as women within families that are known to carry BRCA alterations will need testing. So the cancer risk associated with inherited alterations in BRCA1 or BRCA2 is sometimes referred to as hereditary breast and ovarian cancer, or HBOC. But that name is sort of misleading because it also predisposes to other cancer types. And because breast and ovarian cancer predominantly affects women, it sort of reinforces this myth that only women need to be concerned about carrying these gene changes. Because of those reasons, the name King syndrome has been proposed by some authors as an alternative name to HBOC. That hasn't really taken off, but I can understand why there was an attempt to kind of rebrand it with those considerations in mind. So this table is rather busy, and I apologize for that, but it is useful information just to demonstrate to you briefly. So this team looked at their data in MD Anderson to try and come up with the risks of various cancers that are associated with inherited alterations in BRCA1 and BRCA2. And you can see in the first column there, they've listed out all of the various cancer types that were reported in their carriers. The second column lists the gene in which the alteration was identified. The third column is how many of these cancers they observed in their cohort. The fourth column is how many you would expect to see in the general population. And then the other three columns relate to the standardized incidence rate, 95% confidence interval. And the column at the end is the one that is, those of you interested in statistics will be most interested. This p-value basically is just an indicator as to whether this occurred by chance or not. And anything that's less than 0.05 indicates that it is unlikely to be by chance. So the cancers highlighted in red there are definitely associated with inherited alterations in these genes. The ones in purple, a bit more speculatory, and the ones that I haven't highlighted at all are ones for which the evidence of an association is lacking. So it's pretty incontrovertible that breast and ovarian cancers are increased in carriers of inherited alterations in BRCA1 and BRCA2, and the risks associated with these are astronomical compared to the background population risk. The risks of cancers like pancreatic cancer and prostate cancer are pretty much limited to BRCA2 gene alteration carriers, and the risks in BRCA1 alteration carriers actually are not significantly increased compared to the background population. It is still very relevant to know if somebody affected with those type of cancers carries an alteration in BRCA1, however, because it might influence the kind of treatment that we recommend for them. So we do still, to all intents and purposes, we test BRCA1 and BRCA2 together if we need to test them at all. I've highlighted a couple of cancers in purple here, and the reason I've done that is because some of the data about these is interesting, but also conflicting, and I'll explain that in a bit more detail later in the talk. The cancers there that I haven't highlighted are ones for which an evidence of an association is lacking. So although these cancers have been reported in carriers of BRCA1 and BRCA2 alterations, they don't happen any more frequently than they would in the general population. Because remember, even if you're a carrier of BRCA1 and BRCA2 alteration, yes, you're at increased risk of the cancers associated with those gene alterations, but you're at the same risk of developing any other type of cancer as anybody in the general population as well. So this table here is just the second part of the results from that study. And again, you can see cancers of various different types were reported in their carriers, but actually the evidence that the risk of these type of cancers is increased in BRCA1 and BRCA2 carriers was not supported by this study. So I've just mentioned that the risks of certainly breast and ovarian cancer are significantly increased in carriers of BRCA1 and BRCA2 alterations. And you can see this table demonstrates what the lifetime risks of those type of cancers are compared to the general population. So in a biological female, the risk of breast cancer, if she carries a BRCA1 alteration, is in the order of 65 to 79% over her lifetime, compared to a carrier of a BRCA2 alteration where the risk is 61 to 77%. In either case, they're obviously significantly, massively increased compared to the population level risk of 12.5%, which is about 1 in 8. Biological males that carry alterations in these genes are also at increased risk of male breast cancer, particularly if they carry an alteration in BRCA2. Now, these risks are for individuals that are cisgender, so meaning that the gender with which they identify is the same as the gender assigned at birth. People who are transgender, so people who were born female but identify as male, or people who were born male that are identifying as female, their risks are different and not very well established, and they will also be influenced by what treatments they have had in terms of gender confirmation. So that work is ongoing. Unfortunately, I don't have time to elaborate on those risks here today, but I'm very happy to talk to you at some other stage about those. In terms of the risk of ovarian cancer, obviously the risks are really increased, particularly in carriers of BRCA1 alterations, and as I mentioned previously, the risks of pancreatic and prostate cancer are particularly increased in carriers of BRCA2 alterations. So the cancer risks in people who carry alterations in these genes depend, as I mentioned, on biological gender, but also on things like age, with risks increasing in adulthood predominantly. It also depends on what type of gene alteration you have. So There will be certain alterations in BRCA1 or BRCA2 that might be associated with higher risks than others. We also know there are other genetic risk factors that can modify these risks, and obviously there are lifestyle and environmental factors that need to be considered as well. So currently, the way that we manage the risks associated with inherited alterations in BRCA1 or BRCA2 is a combination of strategies. So for certain cancer types, we can offer screening. So that's particularly useful for female breast cancer. So we have a combined approach. We use either MRI and or mammogram, depending on a woman's age and breast density, and that typically starts from 30, but might be considered from as early as 25, depending on the family history. There's also a role for risk-reducing surgery, particularly to minimise the risk of breast cancer and to minimise the risk of tubo-ovarian cancer. There, unfortunately, are no proven screening techniques for cancers like pancreatic cancer or for ovarian cancer, although research is ongoing in this area. Screening for prostate cancer has been shown to be useful in carriers of BRCA2 alterations, but as yet there is no coordinated national screening program. So here in the UK and in the Marsden, we're very lucky because we have a dedicated clinic to which we can refer people with prostates that carry BRCA2 alterations, but there's a lot of work to be done in this space. Obviously, for any cancer type, we counsel people about symptom awareness and what signs and symptoms they should look out for. And we also talk about lifestyle and strategies that can be undertaken as well. And I'll talk about that in a bit more detail later. If we focus in on pancreatic cancer for a moment, pancreatic cancer often causes huge anxiety when you mention the term, and understandably so, because it's a pretty difficult cancer to identify. It's a difficult cancer to treat, and at the minute we don't have any good screening test. Well, we don't have any proven screening for it. It is important to remember, though, that the risk, even if you do carry an alteration in BRCA1 or BRCA2, yes, it's increased compared to the general population, but the risk overall is still very small. So the risk is between 1% and 5%, and it depends on which gene is involved. Screening, as I mentioned, is not proven to impact overall survival, and at the minute is not routinely recommended outside of a research setting or specialised centres. But there will be research studies and centres that have specialist interest in pancreatic cancer screening that will sometimes offer screening as part of their kind of research protocols. Importantly, I always tell people to just be mindful of new symptoms. Now, it's a fine balance between being mindful and turning completely neurotic about symptoms that might be representative of something else. But the things that we would always recommend be investigated are things like unexplained and unintentional weight loss, persistent pain in the abdomen or sometimes in the back. If you have persistent nausea that's unexplained, is certainly if you have jaundice, so if you notice yellowing of the skin or in the whites of the eyes, or if your urine has started to get very dark, if you have unexplained fatigue, or one that is definitely important to investigate is if you have a new diagnosis of unexplained diabetes. The other thing that I tell people to do is to avoid smoking. So avoiding smoking is good for your health, generally speaking, anyway, but it's particularly useful in terms of managing, where possible, the risk of pancreatic cancer. Smoking is associated with an increased risk of that cancer type as well. So if you do smoke, please stop. And if you don't smoke, don't start. Thank you. So I know the remit of today's talk is to talk about cancers other than cancer of the ovary and breast, but actually in order to do that, I need to give you a little bit of background about ovarian cancer first. So to set the scene, I just want to revise the internal gynecology or gynecological anatomy. So these little grey structures here are the ovaries. So we have two of them generally. This, as you can probably guess, because it looks like a tube, is your fallopian tube. And again, we have two of them, one on each side. This central structure here is the uterus, which is also known as the womb. This bit at the neck of the uterus is your cervix, and that leads into your vagina. When we talk about the cancers associated with inherited alterations in BRCA1 and BRCA2, we call them this umbrella term of ovarian cancer. That really is underselling what we're talking about. It's really an umbrella term that refers not only to cancer within the ovary, but also cancer of the fallopian tube and cancer affecting the lining, the internal lining of the abdomen known as the peritoneum. So you can call cancer of the peritoneum primary peritoneal cancer if you want. You can call cancer of the fallopian tube cancer or tubal cancer, and you can call ovarian cancer ovarian cancer. But when we talk about ovarian cancer, it could potentially be referring to any of these things. And actually, what we think in a significant proportion of cases, what we're calling ovarian cancer or primary peritoneal cancer actually may well have started in the fallopian tube to begin with. The most common subtype of ovarian cancer or fallopian tube cancer or primary peritoneal cancer that you see associated with alterations in BRCA1 and BRCA2 is this subtype known as the high-grade serous subtype. Years ago, it used to be more tricky to figure out what subtype you were dealing with, because the way that pathologists used to figure that out is by looking at it under the microscope, whereas nowadays we're much more likely to do some molecular testing on top of that. So the way that we classify ovarian cancer has changed over time. For many years, we thought that alterations in BRCA1 and BRCA2 could predispose to other types of ovarian cancer as well, but actually the likelihood of developing a different type of ovarian cancer if you've got a BRCA1 or BRCA2 alteration is really low. So the vast majority of ovarian cancers occurring in people that carry these alterations is the high-grade serous type. As I mentioned earlier, current evidence suggests that most high-grade serous pelvic cancer, whether it's ovarian, primary peritoneal, or otherwise, starts in the fallopian tube. And that knowledge is what has started to underpin some of the research studies that are looking at the impact of just removing the tubes on reducing ovarian cancer risk. And we're hopeful that those studies will show that to be the case, but that work is ongoing. So that brings me to talking about cancer of the uterus. Now, in the general population, cancer of the uterus is not all that rare, but it's not the most common either. So about 3% of people with a womb will develop cancer of the womb at some stage in their lifetime. There are certain risk factors that can increase your risk of developing cancer of the womb. The most predominant one, being overweight, certainly has a very significant influence on your risk of cancer of the womb. Getting older, which none of us can avoid. We also know that certain types of hormone replacement therapy, so HRT, particularly if it's estrogen only, also increases the risk of developing cancer of the womb. And that's why people that have wombs are generally recommended to also have progesterone as well as estrogen associated HRT. We know that tamoxifen, which is a drug used to treat or prevent breast cancer, is also associated with an increased risk of cancer of the womb. We know that women who don't have children are at higher risk. Certain medical disorders, including diabetes, have been associated with the cancer of the womb. We also know that family history of these type of cancers or related cancers is going to influence your own risk, and certain inherited genetic risk factors play a role as well. Like any type of cancer, you can subdivide cancer of the womb into different types. Pathologists will often talk about these type 1 and type 2 kind of divisions. Don't worry too much about them. What I'm going to ask you to think about today is a type known as the serous subtype. All you need to know really about the different types of womb cancer is that they look different under the microscope and they have different molecular features as well. So the reason that I have specifically mentioned serous type uterine cancer is because there has been this sort of controversial association between serous type uterine cancer and inherited alterations in BRCA1 and BRCA2. The reason I say that it's controversial is because there have been lots of issues with the available data. So The knowledge that a lot of these serous type gynae cancers start in the fallopian tube is evolving. And historically, those cases that were labelled as serous uterine cancers might actually represent serous tubal cancers that are much more likely to be associated with inherited alterations in BRCA1 and BRCA2. We also know that because BRCA1 and BRCA2 alterations increase the risk of breast cancer, a proportion of carriers will have had breast cancer and will have had treatment with tamoxifen, which in itself is associated with an increased risk of cancer of the womb. The other issue is that a significant proportion of the studies that have demonstrated an association with uterine cancer and BRCA alterations include people that are of Ashkenazi Jewish heritage, and people that are from that background have a significantly higher risk of carrying a BRCA1 alteration, a BRCA1 or BRCA2 alteration by virtue of their heritage anyway. So it may be that this association is by chance rather than actually being true. What is clear, even in those studies that have demonstrated an association, the risk overall of developing uterine serous cancers appears to be very low, albeit increased compared to controls. So it's not a clear picture that we're dealing with based on current information. So this is a screenshot of a table that was generated by De Jong et al. Back in 2017, and they looked at this in quite a bit of detail. And you can see that this table is really interesting actually, because it just demonstrates some of the issues in the studies that were reported. So in a lot of the studies, the cases weren't reviewed by an expert pathologist. In a number of studies, there wasn't full testing done of BRCA1 and BRCA2. In some of the studies, they only commented on people of Ashkenazi Jewish heritage. In most of the studies, they omitted data related to previous tamoxifen use. And there were also issues in terms of follow-up, trying to figure out if they gave people enough time to actually record information about cancer development. This next table is again from the same study, and this time they looked at, in those studies that included people with uterine serous cancers, what proportion of them were found to carry inherited alterations in BRCA1 and BRCA2. And you can see there's huge differences in the rates of detection. So in some studies, there was 0% of people were found to carry alterations in BRCA1 or BRCA2. In some studies, it was as high as a quarter of the patient group. But you can see those studies where there are very high rates of pickup, the people were of Ashkenazi Jewish ancestry. So that's a source of bias in general. And you can see the numbers included in these studies are quite small as well. So it's hard to draw any hard and fast conclusions based on this data. The other way that you can look at this is to look at people who are known to carry BRCA1 and BRCA2 alterations and figure out how many of them went on to develop uterine serous cancers. And these are two different studies looking at this point. And again, if you look at the first table on the left-hand side, you'll see that the numbers of patients that carry these alterations that go on to develop cancer are very, very low. So in two of the studies there, 0 patients developed cancer of the womb. In the last study, 4 people developed cancer of the womb. In another study, the table on the right hand side, you'll see that there were very tiny numbers. So 5 out of a total of 821 individuals that developed cancer of the womb in that particular study. So the risk overall seems to be very low. This is more recent work. So this systematic review was published last year, and they looked at the same topic. So how many patients that are known to carry inherited alterations in BRCA1 or BRCA2 went on to develop cancer of the womb. The numbers are very small, and in most of the studies, even if they showed an association, it seemed to be limited to only BRCA1 rather than BRCA2. But again, because the numbers are so small, it's very hard to draw any hard and fast conclusions from this work. This study was an interesting piece of work done by a group in Israel, and they showed that the risk of any type of cancer of the womb appeared to be increased compared to the population. So when you think about all types of cancer of the womb, the risk seemed to be increased by a factor of 2. The risk overall was still very low because remember, cancer of the womb occurs in only about 3% of people overall in the general population. So you're talking up to about a 6% risk. However, the interesting thing about this study is when they restricted their analysis to looking at the serous type of cancer of the womb, that risk was increased by a factor of 18%. And the reason for that is that serous type of uterine cancer only accounts for about 5 to 10% of cancer of the womb. And what the authors in this study suggested was that the reason that we haven't seen a very clear association with cancer of the womb in carriers of BRCA1 and BRCA2 alterations previously is because we've been comparing to the rates of all types of cancer of the womb rather than just restricting it to the serous subtype. So they have certainly suggested that this appeared to be a true association. But again, the risk overall, even if this is true, although the relative risk, so an 18-fold increase compared to the background population risk, in general terms, that actually translates to a risk that is very, very low overall. At the minute, the way that we manage cancer risks associated with BRCA1 and BRCA2, if we think about the gynae risks, screening unfortunately hasn't been proven to influence overall survival from cancer of the fallopian tube or of the ovary. So at the minute, we don't recommend screening routinely. The only proven way of minimizing the risk of cancer of the fallopian tubes and ovaries is to have risk-reducing surgery to remove the tubes and the ovaries. That's typically undertaken around the age of 40 and not before the age of 35 unless there's a very strong family history of early onset ovarian cancer. And the surgical team and pathology team worked together and used this protocol known as the sectioning and extensively examining the fimbriated end CFIM protocol. All that means generally is that the fallopian tube is examined very, very carefully, looking for features suggestive of precancerous or cancerous change. I'm sure many members of the audience will have undergone this surgery and can probably speak at length about the advantages and disadvantages associated with it. But just to give you a brief insight, so, no young woman is going to be signing up for this surgery lightly because there are significant disadvantages associated with it. So obviously, if you have your ovaries and fallopian tubes removed, it impacts your fertility and you won't be able to have a pregnancy naturally without assisted reproduction techniques. It throws you immediately into the menopause, and this is the big issue for a lot of people. There are increased risks associated with having an early menopause, and they include risks of heart disease, of cognitive issues, of osteoporosis. So it's not something that should be undertaken lightly, and that's why we have said that we would not recommend this surgery before the age of 35, because your risk before that age, even if you carry an alteration in one of these genes, is very, very, very low. And actually the risks associated with the consequences of having an early menopause are bigger than any benefit at that young age. But certainly as the risk starts to increase, the benefit of this surgery starts to outweigh the risk. So certainly if your ovaries are still in place when you're 49 or 50, I would be coming to you looking for them, because they're not going to be any advantage to you after that, and they will start to just carry a risk that's very significant. The advantages of this type of surgery, it allows detection if there is any kind of precancerous or cancerous change. It allows detection earlier than if you'd allowed the woman to become symptomatic, and that allows more timely treatment. It definitely reduces the risk of cancer of the fallopian tube and ovary. Most of the literature will quote this remaining risk for cancer of the peritoneum, which, as I mentioned earlier, is the lining of the inside of the abdomen. This risk is the risk that's quoted overall is about 4%, but actually the risk is very significantly increased in people that have evidence of precancerous changes in their fallopian tubes. The precancerous changes that we're looking for include these things known as STIC, so serous tubal intraepithelial cancer. That's just a fancy way of saying precancerous change. If you don't have evidence of that in your fallopian tube, actually your risk of developing primary peritoneal cancer after that type of surgery is very, very, very low. And as I mentioned earlier, there's some work ongoing looking at whether risk-reducing surgery can be done in 2 stages, taking out the tubes first and going back after the menopause to take out the ovaries. And we look forward to seeing the results of those studies in due course. So with all of that in mind, a very reasonable question that I'm asked not infrequently is whether we should be taking out the womb at the same time as the fallopian tubes and the ovaries. And the potential advantages of doing that is that it reduces the risk of cancer of the womb, which might be particularly relevant for women who have had tamoxifen for treatment of a breast cancer, because tamoxifen in and of itself can increase the risk of cancer of the womb. It also removes the need for progesterone replacement, progesterone HRT after surgery, so the women can have estrogen only HRT after risk-reducing bilateral Salpingo-oophorectomy if they need it, if they have their womb taken out at the same time. There has been some data to suggest that it increases the survival. Now, I would ask you just to take a second to note that the increased survival that they talk about is 4.9 months. So they're not talking years, they're talking months here. And it has also been shown to be cost effective. The disadvantages of this type of surgery, it is much more complicated than just taking out the fallopian tubes and ovaries. It's a bigger operation, it's associated with longer recovery, and there are not insignificant risks associated with it. These include things like infection, clots, damage to other organs, and also in the longer term you need to think about things like vaginal prolapse and other consequences as well. It also makes things like having colonoscopies more difficult, etc. So there's lots of things to think about. It's certainly not something I would be signing up for lightly. The other thing, and the thing I need to remind myself as well as the people in front of me, is that the risk of womb cancer overall, even if we consider all of these associations to be real, the risk even in those studies that have shown an association is extremely low. So the number of surgeries that you would need to undertake to prevent one cancer in this group is about 40. And you know, the potential risks associated with the surgery, it's actually not clear if the benefits are greater than the risks. So at the minute, we don't typically recommend taking the womb at the same time as the fallopian tubes and ovaries. However, if a woman has some other associated problems, so if she has very troublesome fibroids, or if there's some other reason where taking out the womb might actually be associated with a benefit otherwise, then you would potentially consider it at the same time. So it comes back down to an individualized assessment and going through the data in quite a bit of detail. But the one takeaway that I would like you to get from this is the risk overall. We're not sure if we're not completely conclusive about it as yet, but if it's true, it's extremely low. And the surgery is not insignificant. So the other cancer type that comes up in various studies is melanoma. So the association again is unclear. Some studies show an association with BRCA2 alterations, some studies show an association with BRCA1 alterations, and others show absolutely no association at all. And the difficulty with melanoma and skin cancer in particular is the risk of skin cancer is so heavily influenced by environmental exposures. So your exposure to the sun, how often you've been sunburned over your lifetime, and what skin type you have. So I know you can't see me today, but I have Casper the Friendly Ghost type skin. I get burnt as soon as I look at the sun. So I would be much higher risk of developing skin cancer than somebody that had a more sallow skin type. In general, although the risks, look, it's all very woolly, the data is not very clear, etc., 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 I think it's very sensible, even if you didn't carry an alteration in one of these genes, to try and minimize your risk of skin cancer, particularly if you're fair-skinned and particularly if you're working somewhere that involves a lot of sun exposure. So try to avoid getting scalded if you can at all. You can do that by avoiding direct exposure to the sun between the kind of peak hours of 11 and 3, so just covering up with long sleeve tops, etc., using sunscreen and a good quality one, and making sure to reapply liberally throughout the day. Now, people that avoid the sun do have a risk of vitamin D deficiency, which is a particular problem in this part of the world where we don't get a lot of sunlight anyway. But you can get vitamin D from other sources. So good sources include things like oily fish, egg yolks, meat, cheese, etc. The other thing to be mindful of is if you are moly, so if you have lots of moles, just be aware of any changes, and this might need help from a partner, because obviously it's not very easy to see things on your back. So you may need somebody just to have a quick squint every now and again. If you are worried, please ask your GP. You may even benefit from a referral to a dermatologist if you have lots of these moles. There's a nice acronym known as the ABCDE kind of process for reviewing your moles. So A stands for asymmetry, so does one half of the mole look bigger than the other? B is for border, so is the edge irregular? C is color, has it changed? Does it look very dark? Has it changed over time? D is diameter, so is it getting any bigger? And E is evolution or everything else, basically. So has it changed in some way? Is it starting to bleed? Has it got very itchy, etc.? Any of these signs should trigger, please seek advice from your GP, and they may well refer you on to a dermatologist for a further review. The other cancer type that is of interest as well is cancer of the stomach. So cancer of the stomach in the general population, there are slight differences between biological males and biological females. So we know about 1 in 76 men will get stomach cancer over their lifetime, and about 1 in 130 women. There are certain risk factors that have been identified. So we know that increasing age is associated with an increased risk of most cancer types. Again, being overweight, smoking, certain environmental and dietary factors, and infection with the bacteria, so a bug known as Helicobacter pylori, that increases the amount of acid production in the stomach, which can be associated with an increased risk of stomach ulcers and in turn an increased risk of stomach cancer. The association between inherited alterations in BRCA1 and BRCA2 and stomach cancer is not all that clear. So the data in the literature again is conflicting. Some studies have shown an association, some studies haven't. Some studies seem to associate or to show an association only with BRCA1, others with only BRCA2. In most studies, it seems that the risk is most pronounced in men compared to women, but none of it is very clear. There is definitely a strong impact of Helicobacter pylori infection. Overall, screening for stomach cancer, even in people with other genetic risk factors associated with a very high risk of stomach cancer, screening is largely unproven. So we don't have a very robust screening pathway for people at higher risk of stomach cancer. I, for the last couple of years, have been recommending that my carrier or people that I look after that carry alterations in BRCA1 or BRCA2 ask their GP to organise Helicobacter pylori testing for them. It's a pretty easy test. Most places do it now on a stool sample, which is not the most glamorous test in the world, but it is pretty easy to do. So you just collect it at home, drop it into your GP. Some GP practices use blood tests, some use breath tests, etc. Treatment for Helicobacter pylori infection is pretty easy. So it's a course of antibiotics with proton pump inhibitors, which are drugs that impact acid production in the stomach. And that has been shown to help modify the risk of stomach cancer in general. And some recent data shows it's particularly useful in people that carry alterations in these genes. So just in finishing up, I would ask you always to remember there are certain things that you can control. So you can't control your genetics. Look, you're born with what you're born with. That's true for all of us. We all carry little blips that increase our risk of different types of health issues. What we can control are our lifestyle factors. So alcohol is associated with an increased risk of certain types of cancers. So try your best to moderate your alcohol intake. You don't need to be teetotal, but stick to the recommended maximum allowance per week. Try and exercise as much as possible. Exercise is only a good thing. Now everyone's tolerance is slightly different, but a 20-minute walk every day is hopefully achievable for most people. Try and maintain your weight at a normal BMI level if you can, because being overweight is associated with an increased risk of lots of different types of cancers. In terms of diet, it's very boring, but lots of fresh fruit and vegetables will really be very good practice in general. A lot of these fad diets, like very low sugar, very low carb, etc., I don't give in to a lot of them. There's the data behind them is depending on a lot of different factors and can be quite woolly. So my general kind of advice is plenty of fresh fruit and veg. Limit red meat to kind of once a week if you can. Lots of oily fish. But generally just a nice varied diet is usually helpful. And definitely avoid smoking. Smoking is not, there is no health benefit to smoking. Please don't start if you don't smoke, and please give it up if you do smoke, and your body will thank you for it. So I hope that has been helpful. I'm very sorry that I can't be with you live. I'm sure I'm missing a great day. It's always a fantastic session, and a huge thanks to the Marie Keating Foundation for inviting me to speak, and also for the work that they do. It's really a phenomenal organisation, and I'm delighted to contribute.